Hi, good evening, ladies and gentlemen, my distinguished panelists, and all my viewers. I am Dr. Nishant Sharma, and I welcome you back to the series of virtual discussions on arthritis in India, a national wide dialogue. This series is a joint initiative by Voice of Healthcare and Pfizer, where we will talk about the different spaces in arthritis and its care in the India. We will be discussing about the different types of arthritis, the different management strategies, the advancements for patients living with arthritis, and the strategies for improving its care. I welcome my experts from different parts of India. Today we have with us Dr. DBS Jaggi, Associate Professor, Orthopedic and Joint Replacement, Max Healthcare, Gurugram. Good evening, sir.
Good
Welcome.
evening. Good evening.
Thank you. We have Dr. Ramkinkar Jha, Chief and Head Orthopedics, Artemis Hospital, Gurgaon. Good evening, sir. Thank you for joining.
Hi. Thank you for
And we have
giving
with
me.
us Dr. Major General D.S. Bhakuni, Director-Rheumatology, Max Hospital, Vaishali and Noida, and Dr. Naval Mendiratta, Senior Consultant Rheumatology, Fortis Memorial Research Institute, Gurugram. Both of these doctors are running a little short on time. We will have them in the session as they join. So, with both of you, we would want to start this conversation in trying to understand arthritis. So, I will start with Dr. Jha. Dr. Jha, my question to you will be: what is arthritis, and give an overview on the different types of arthritis that are prevalent in India.
Okay. So when we speak about arthritis, it's a very complex word to say because it's a umbrella under which many diseases comes. So arthralgia is a symptom the patient tells us that we have pain in joint. That is arthralgia. And on X-rays, when we appreciate there is changes, that is permanent, irreversible changes, then we call it arthritis. And once this arthritis term is being understood, we can subdivide it into different parts. Like one, it can be anything: inflammatory, non-inflammatory, traumatic, non-traumatic. So the most common being is the age-related, that is osteoarthritis. Second
Mhm.
being most common is the post-traumatic, and the third more common being the inflammatory, where the rheumatoid arthritis, or the common term in our country we use Gatia. It could be gouty, it could be rheumatoid, it could be ankylosing spondylitis. So these are the subcategories of arthritis.
Thank you, Dr. Jha, for a good introduction to the conversation. Moving over, Dr. Jaggi. My question to you will be: please describe the common symptoms and signs that we see in arthritis, and also put some light on the key risk factors that are associated on developing this condition. Dr. Jaggi, please.
I think I would carry on from what Dr. Jha said. This arthritis is actually a very vague term. It's a very encompassing term which covers almost like 100 types of arthritis. I'll stick more to osteoarthritis, which is actually the most prevalent form.
Mhm.
India, for a weird reason or maybe historical, rheumatoid has gotten a lot of weightage or traction, I would call it, because anything not understood would become rheumatoid.
Hmm.
And even now in my practice, I would see a lot of patients who are on rheumatoid or anti-rheumatoid drugs with no evidence of rheumatism in them as such. So the symptoms of arthritis per se, as we look at it, it's essentially a wear and tear of joints. So the cardinal symptoms remain same. The subtype or the causative thing can be different, but the essential things are pain, stiffness, loss of movement. So sometimes a bit of swelling of the joints. So these are the few basic symptoms. Like these symptoms are like
Mhm.
will fit almost everything. The biggest
Right.
thing is pain, stiffness, reduction of movement, and some swelling. Sometimes the joints can feel a bit warm or hot also. Sometimes you can hear sounds from it,
Mhm.
and sometimes you can see deformities also. So this all depends on the severity of the arthritis or the grade of arthritis coming through. So it's not that everybody will have every symptom. It's
Mhm.
essentially a bouquet of symptoms, and these bouquet of symptoms, somebody will have. a few symptoms coming through. So it's the whole clinical picture, and the clinician, either it's a surgeon like me or Dr. Jha or a rheumatologist, we join the dots, looking at the clinical symptoms, looking at their investigations, looking at their
Mhm.
radiological, and but essentially it's wear and tear of the joints.
Right.
Now, is it a natural process by you aging, or is there a disease process like maybe gouty, rheumatoid, psoriatic? So, in the end, the joints are getting worn out. And when we say joints, it's not only the cartilage, it's also the
Mhm.
soft tissues around it. So, I hope I've not made it more confused. I've just tried to
No,
simplify it
no.
as much as I could.
Right, sir. Right, Dr. Jaggi. I think what both of you are trying to say is osteo or arthritis particularly requires a lot of clinical analysis before trying to understand which arthritis it is, what are the
Yeah.
causes behind it, and hence you develop what treatment modality you think on it. Uh, while we speak of diagnosis, Dr. Naval, are we audible to you? Yeah. Hi, Dr. Naval. Good evening.
Good evening.
Good evening, sir. We were just discussing with Dr. Jaggi and Dr. Jha about what arthritis is, what are the different types of arthritis, and the common signs and symptoms we see. My question to you will be: I want you to emphasize what early diagnosis has an impact on the overall treatment outcome that we see with individuals in arthritis.
See, with osteoarthritis still remains one of the commonest. Or like the patients, what we see in our age groups are very young age groups, like from 20 to 40 years, when they start having the symptoms of joint pain, stiffness, swellings. And these are the symptoms when we catch them early within first 6 months, we are able to completely reverse the inflammations. Over time, everybody does degenerate, everybody does develop an osteoarthritis, but at least at a certain age, if you are able to treat these inflammatory conditions, they have a very good outcomes in halting the disease. And arthritis just doesn't remain limited to the joints. So that's what we tell our patients. Even like rheumatoid patient of more than 10 years will may develop a lung disease also. He may develop eye complications also. The cardiovascular risk is very high in these patients if they leave the uncontrolled inflammation. So when we look at the arthritis, we look at it like diabetes, that you have to make sure that all the other organs which can be impacted by disease are not affected. So it's basically
Right.
covering the whole domain and halting the process there.
Right. Thank you, Dr. Naval, for putting your views on the topic. Moving over, let's talk about the different management strategies. Given that I have two surgeons and one rheumatologist with us in this conversation, I'd like to go one by one and understand the different kind of treatment modalities that are being used to treat different arthritic patients by all of you clinicians. I'll start with Dr. Jha. Uh, for you, please share some effective strategies for managing arthritis, both medical and lifestyle or surgical approaches that you usually take in your clinical practice, sir. Please, Dr. Jha.
So once the patient comes with the like symptom, um, first thing would be diagnosis, whether it's osteoarthritis or inflammatory arthritis. Like Dr. Naval told, that if you catch those inflammatory arthritis early, there is a way we can retard, if not reverse completely, at least retard. So it's very, very important to first diagnose. And that starts with very simple like clinical examination or simple x-rays for osteoarthritis. Weight bearing x-rays are sufficient. But in case of like inflammatory, we need some battery of blood tests also, that includes RA factor or anti CCP and other thing that Dr. Noble maybe elaborate in his views. Once the clinical examination, investigation, other thing, we look about the stage of arthritis and how this arthritis is impacting the activities of daily life. जैसे हम कहते हैं दिनचर्या कैसे प्रभावित कर रही है. So we see how much disability this arthritis is causing, age, occupation, profession, because everything, the algorithm in these are inputs actually. A laborer having like poor socioeconomic group is coming to us, and a say 60-year plus patient with sedentary lifestyle with good financials. So treatment will vary on that. So first thing is diagnosis. Second is the stage. Third is expectation from the treatment. Like everybody wants to be pain free, fully mobile, but how we can offer those things. So there are battery of after this battery of tests, there are different counseling. What are the expectation? Like for example, a laborer having stage 2 osteoarthritis, we would like to preserve the joint, like joint preserving surgeries, high tibia osteotomies, and other things. Compared to say 70 year, 80 years having pain and a sedentary lifestyle, so we would like to give them a joint replacement as a treatment option. Okay.
Right. Thank you, Dr. Jha, for putting forward your views. Dr. Naval, my same question towards you as well. In your clinical practice, in your day to day, what are some effective strategies that you utilize for managing arthritis for your patients, both in terms of medical or surgical opinions that you provide? Please.
Uh, do only. So medical part,
So you're having a poor internet. Uh, Dr. Naval, your internet
let me
connection
check it.
isn't stable. Please.
It's any better now?
Yes, it's
Yeah.
better. You're audible, sir. Please.
So for initially, as Dr. Jha also said, diagnosis is the most important thing. So one, we have to look at if it's how active is the rheumatoid arthritis. If it is a rheumatoid, does he have any secondary osteoarthritis changes? Because osteoarthritis is something which we may not be able to reverse much with the medications. So that's where we take a help of our colleagues as well from there. So mostly for rheumatoid arthritis, we do have all the DMARDs now to start with, maybe methotrexate, leflunomide, hydroxychloroquine, sulfasalazine. And then you have the newer category of drugs, the biologicals also. So we go towards them once we feel the patient is not adequately responding to the DMARDs or some extra articular complications apart from arthritis like lung involvement or eye involvement. Definitely at some places we do find some joints get stuck. There has a lot of synovial hypertrophy. So that's why we get orthopedics opinion also that rather than increasing the DMARDs, at least we can do a synovectomy or some fusion which they are able to offer us better with that.
Right. Right. Thank you, Dr. Naval, for putting forward your opinions. Moving on, Dr. Jaggi, my next question will be for you, building on the previous conversation between Dr. Jha and Dr. Naval. Any recent advancements or innovative treatments in arthritic management that we have witnessed in the last couple of years or the last decade that you mind exploring, please?
We have made advances on 2 points. One is the medical advancements, one is the surgical advancement. Medical advancement has been that we have come up with better NSAIDs or COX-2 inhibitors, which have lesser, they don't really hit the stomach that hard, or the cardiovascular complications are much less. We have come up with the biologics, which our rheumatological colleagues use. So these sort of things, what they have done is they have increased that armamentarium which you have, that what all can we offer the patients. We can even painkillers or these NSAIDs, they can be now given much longer, though they all come with their caveats. There's no such thing as a perfect drug, but the safety profile has increased. One. So monitoring is much better. That's from a medical point of view. And because arthritis has been understood and is being approached now more as a systemic problem rather than a localized problem, I think overall the patients are being managed way better. One. The second thing is, as far as surgery is concerned, what has happened is in the last decade or more than that, the implants have improved, surgical techniques have improved. We have got longer lasting implants. So what has happened is initially we would be looking at an implant lasting an X number of years. Suddenly that envelope has increased. So your options have increased. Again, in this, the patient profiling has I would say in the last decade, there's a sea change in the profiling of patients. Patients are now much more informed. They are much more demanding, I would say. People all want to live today. A lot of the times, I think my colleagues would agree with me. At least I see a lot of patients who come and say, "Sir, how can my next 10 years be better?" Who knows? Ki
Right.
they give the example of either COVID or they'll give an example of something you never know what happens. But where can we get our life back? And initially, some treatments which were only reserved for special categories that at a certain age, ye sochenge, or we'll
Mhm.
offer this at a certain age. I think those boundaries are being pushed now, and I think it's a team effort which is making those boundaries being pushed. So the results are better, the outcomes are better, and again, there's some risk involved, absolutely. But I think it's on the whole, uh, I think we're all getting a bit more, I would say, emboldened by the newer drugs and the surgical techniques both combined. It's a combination coming together.
Right. Thank you, Dr. Jaggi, for elaborating on the particular answer. Moving over, let's talk about for patients who are living with arthritis. I'll start with Dr. Jha. Any coping strategies that you recommend for individuals to effectively manage arthritis in their daily lives that you usually deploy in your clinical practice, Dr. Jha?
Okay. So once like we look into the reasons why the patient develops arthritis. Say for example, we are discussing the most common being the osteoarthritis. Like we look for the reasons. Age is definitely one of them, but as you mentioned earlier also that younger patients are also affecting. So first thing, the weight, optimal weight. High BMI status is one of most common risk factor for developing osteoarthritis. So maintaining and keeping a record of body weight is one of key factor in retarding the progression of osteoarthritis. That's number one, and that's also helps in even if you do the joint replacement, other things also that also helps. So in case of morbid obesity, we may need to like refer them for bariatric surgery also if they have morbid obesity. So that's the first. Second is the lifestyle modifications, like
Mhm.
what we tell our patients to reduce the activities which has some impact on the knees. Say, for example, in India, knee is the most common joint which is affected in osteoarthritis. So, like sitting cross leg over the hard surface, squatting postures, taking much. Some patient having misconception also. They
Mhm.
take stairs as like exercise. So we teach them that no, you need to like take care of these things. Don't take more steps than what is required. Some has misconception conception about the treadmills. They are more rely on those technology and other thing. But I would say the natural walking is a better option than the having treadmill, especially if you are for space constraint. If you are using treadmill, keep the speed less than four something, no? So there are few things. Other than that, some food habits, some they helps in reducing the symptoms or severity of the osteoarthritis. Like in our practice, we tell patients to take turmeric. It has some anti-inflammatory as well as it's a counterproductive one. There's a natural thing having less side effects. So using kneecap while
Mhm.
walk or like in difficult terrain where there is uneven surfaces, so they can use kneecap for a while. They also helps. Doing regular exercises, especially those
Mhm.
exercise which is like quadriceps strengthening exercise, quadriceps muscles. Those are the key muscles. So they help in reducing the pain intensity, if not
Mhm.
reverse. They help in coping up with the arthritis.
Thank you, Dr. Jha, for putting some light on the different strategies. Moving over, Dr. Naval, my question for you would be, could you discuss the support systems and the resources that are available to help individuals with the arthritis lead full lives? And any support systems or initiatives that you particularly know of?
Not particularly. I think a lot of times we are still struggling to provide patients the better treatment. As like we discussed about biologicals also, there's only if you tell 10 patients, one may be able to afford it to take it also. So that's why we still need to work a little more on that, how to develop these systems. Insurances do not even cover most of our drugs. Like for the chemo, we still have a coverage. But for biologicals, if you admit patients, it's outrightly rejected. Support groups is something we can look at. We do have a support group in India for a few diseases like scleroderma, Sjogren's syndrome. But arthritis, ankylosing spondylitis, which are much more prevalent, we still do not have much of the help there. And so we're just looking at something more support for financially at least as well. So the patients who cannot afford and who really need biologicals are able to at least approach them.
Right.
So
right.
not
Thank you.
much I'm aware if anything else is working. So, but
Okay. Thank you, Dr. Naval. My next question will be for Dr. Jaggi. First, if you'd like to add to any point to the last question I asked from Dr. Naval, Dr. Jaggi, please.
See, I'll be very frank, we are way behind the West. I did all my training and I worked in UK for almost 13, 14 years before coming back to India. Over there, support groups, government funding, helplines. Because see, arthritis, the moment we start looking at arthritis as a medical problem, I think we're missing the bus. Arthritis is not only a medical problem, it's a social problem.
Okay.
What it does is it starts impacting the person, it impacts the patient, it impacts the patient's family. It could be any type of arthritis, rheumatoid, osteoarthritis, psoriatic, gout. There's misconceptions. Inko ho gaya, mujhe ho jayega kya? You know, that sort of a thing. Patients who get it, invariably India, because the support structure is not there, and what Naval was saying that insurances don't cover, then financial portion comes into the picture. Now they somehow, the way patients are addressed in India, they are told, okay, you get this treatment done, this will give you results. Their hopes get high. Now the insurance rejects it. They're financially not secure, so they feel low key. You know, we have missed a golden. They don't realize that those biologicals are not magic bullets, but the way they are told ki ye kara lo, so you will get. You understanding what I'm trying to say?
Right,
So
sir.
when we don't address this at a social level, most of the patients with arthritis, especially with early onset arthritis, majority of them, again, I'm telling you from my experience, from the volume I see, a lot of them are depressed because they see people around them, their age group, going around enjoying life. They're getting mixed signals because see, the problem with India is what we call as it's almost like shopping, window shopping. They'll come to me, they'll go to Ramkinkar, they'll go to. So, everybody can say it slightly differently. Now they are trying to see which one, they like it better or suits better. But what that does is it messes up their mind. A lot of the time, you talk to such patients, after you talk to them 5 minutes, 10 minutes, write them, they will slowly put their hand into a packet and take out a paper and say, Sir, वो डॉक्टर साहब ने तो ये बोला था, उन्होंने ये क्यों बोला? Now, see, what is happening is they are trying to, attach two different things. Naval might have said something to them or from a rheumatology point of view. I am telling, or Ramkinkar is telling them from a surgical point of view. You see, it's a different thing. So, as long as we are not addressing them holistically as a complete package,
right, sir.
When we start looking at them like as individual people, like I only look at them from a knee point of view or from a hip point of view. Somebody looks at them from a biological point of view, and we are not looking at it that the patient is not accepting his disease itself.
Right.
For me, such patient I think should be first seen by a psychiatrist.
Right, sir.
I think it has to be a complete thing where we are not only, arthritis is not what we look at only one joint.
Hmm.
It's their quality of life which goes for a toss. It's the activities of daily living which suddenly become a pain. It's the
Right.
social life, or they want to enjoy life, or they
Yes.
want to
Yes.
do certain things which you take for casual. But for us, some things can be very common, like let's go and
Hmm.
dance. They say we can't get
Right.
up dance, so. So
Right.
you understand
And
what
with,
I'm
with
trying to
such a
say? That,
complex disease, I think that is how it requires a multidisciplinary approach, like the one
yes,
that you're
and
mentioning.
for
Right.
unfortunately in India, we don't have a very good support structure.
Hmm.
But before we really hit the doctors, the rheumatologists, the surgeons, we are tertiary providers. I'm saying, where is the primary and secondary providers?
Right. Right. So thank you, Dr. Jaggi, for pulling out this specific set of information. Uh, Moving over, I would want to understand and pick both of yours brain on some regional insights and the challenges that we see in arthritic care delivery. So, as we know that there are notable regional differences and variations in arthritic prevalence in different parts of India. So, I'll start with Dr. Jha. One, please comment on this about the different variations and the prevalences that we see in different parts of India. And do you feel there are certain specific challenges or barriers that exist in certain regions when it comes to providing quality arthritic care? Dr. Jha.
Yeah, certainly. See, if you see the patient profile, so one thing is financial, as Dr. Jaggi mentioned.
Mhm.
So patient coming from poor socioeconomic setup, nothing to like discriminate, but they are not able to afford the simple painkillers.
Hmm.
Forget about those viscoelastic supplementation or other thing, PRP therapy, stem cell therapy, which cost 1.5 lakhs, say, for example. I can't prescribe those things, no? In those. Second
Right.
is this a one variation? That is the financial. There are extreme of variations. No? Second is about the patient education.
Hmm.
Like Dr. Jaggi again mentioned, patient denial and their understanding. That makes us our work very easy. A patient is educated, well aware about and receptive about the concept of management, then the things become better. Now coming to a regional variation, I'm, I think you are pointing towards a regional variation. So
Right.
see,
Sir.
people coming from villages, they have very good lifestyle, very good food habits and other things. So their way of living, like say, for example, using the Indian toilets, is there. Their culture sitting over the floor, having food there. Like
Right.
if you go to Kashmir, people, uh, many parts, in fact, they have habit of sitting on the floor, sitting cross leg and having food. So this makes important inputs in our decision making also.
Okay.
Other difference is like people living in what I have seen, and in fact, I am very commonly involved in their like with NGOs and other group. I am associated with the like say for Dalai Lama Trust and other trusts. So in hilly area, even for severe osteoarthritis, if we give them surgical options, say joint replacement, it's not feasible for them
Hmm.
because chances of failure post surgical is very high. Say they won't take it as a treatment option, and rightly so. So in those conditions, we slightly change. We try to give them comfort, like say minimally invasive something, arthroscopic lavage and injection stem cell, PRP, anything which is not that invasive. So those patients coming from the high hilly areas, uh, having different expectation and having different treatment modality to offer.
Right. Thank you, Dr. Jha. My same question for you, Dr. Jaggi, talking about your views on the different, let's say, socio-economic patients that we see, different age groups that we see, different demographics we see. Over to you, please.
A couple of things here I would just add. I agree completely with what Dr. Jha just said. See, a lot of the treatment now, medical treatment is getting expensive day by day.
Hmm.
It's in India, the biggest challenge is affordability. Now, the moment, like I work in a place, I work in a hospital which has got no panels. So our practice is slightly different. And why I brought this thing up is suddenly when there are panels, I see patients. There is acceptance of a treatment. Unfortunately, in India is predominantly financial. As long as somebody else is paying, they would still agree to that. So if having an insurance or having a panel which is covering it, then that treatment is acceptable. So unfortunately, the empowerment of the patient per se, there's where this education which comes in.
Right.
I think the patient should decide rather than letting the people around him or her to say this treatment is not good or is good, or we should do it because panel. Do you have panel? Okay, then fine. So what I'm trying to say here is, I think a slightly different thing I'm trying to say, that the treatment should be done on its merits rather than the financial part of it.
Right, sir.
Unfortunately, in India, because the government setup is failing the people badly, it's the private sector is having to pick up the slack
Hmm.
because there's no enough support from the government's point, like hospitals, for these sort of patients. These are long term patients with high complication rates. So what is happening is, uh, unless and until there is an education, but what I can
Hmm.
say very clearly is, whenever you see people who come who are slightly better educated, who come from a slightly better socioeconomic background, sending the message across, the resistance is, you can make them understand at least.
Right. Right.
For people who come from very low socioeconomic status, they might come and listen to you, but you have to put yourself into their shoes.
Hmm.
Whatever you're trying to tell them, they've never heard of it before.
Right.
So they look at you and say, what is this German and French? My doctor over
Hmm.
there said, ये दो गोली खाओ ठीक हो जाएगा.
Right.
But two गोली is actually steroids.
Hmm.
So what is happening is, there is a lot of misinformation,
Hmm.
and I think that is where we need to start first. That start giving the right information,
Right.
empowering the patients in a way where they come and ask the right questions.
Right.
That if there is a biological compound, they should come and ask, sir, I have read about this, ये biological मेरे लिए है क्या?
Right, sir. So education, patient education will.
Patient education is for something like arthritis is extremely important,
Hmm.
because it is
Right.
affecting their quality of life.
Correct.
You have to understand, look at a patient of arthritis whose joints, arthritis basically affects the joints. So think of you as a car, the engine is working, the
Hmm.
brakes and tires are not working.
You will not be able to be mobile, obviously.
Yes, so your brain is working,
Hmm.
you are fine, but your mobility is gone. And
Correct.
if you go back to class 8 or class 7, one of the definitions of living organism is mobility.
Correct.
If you have to say, how do you define a living organism, is mobility.
Mobility.
Arthritis takes away that mobility.
Correct. Right, sir. Thank you. Thank you, Dr. Jaggi, for commenting on that point. Building on your particular conversation about strategies for improving the arthritic care, like you had mentioned, we have to start with patient education. So, awareness campaigns such as this, that Voice of Healthcare and Pfizer are hosting, are also an example. Dr. Jha, my question to you will be ki how can healthcare providers and communities and caregivers and the general public work together to improve arthritic care at a district level? Anything on the top of your head for this, please?
Certainly, see, we are aware about the like medical facilities in metro cities. Once you go like say 100 kilometers from the metro cities, the life is entirely different.
Mm-hmm.
The sorry to say, but the standards of the healthcare is very bad. Especially as Dr. Jaggi mentioned, the government setups. Bearing few states where certainly government hospitals is still working very well. For example, say Gujarat or Kerala or Bengal. Uh, I belong to a northern state which is very poor, and there hardly any healthcare facility available for say 20 kilometers, 25 kilometers. Even if you get a heart attack, it's very difficult to save them. Forget
Right.
about arthritis, which certainly gives time. Okay,
Hmm.
so talking about district level now, recently I think there's an initiation of medical college is opening in all district level. So currently each district in India having one medical college. Whether they have faculty or not, I'm not sure, but if they are implemented very well, say medical colleges level, district uh, primary healthcare center level, if we can screen those diseases early, and some kind of education we can give, some kind of template, say roadmap, that in coming years you need to do this annual checkup or something, so we may help in some way. I think that's the first one. Second is the availability of those essential medicines in those primary health center, other things, genuine and good, like doctors and
Mm-hmm.
support system like physiotherapists should be available there in their district level. So
Right.
long, there's a long journey ahead, dreaming that in most of part of India actually right now.
Thank you, Dr. Jha, for that answer. Building on what Dr. Jha was just talking about, Dr. Jaggi, the next question will be the collaborative efforts or partnerships that have proven effective in combating arthritic cases and combating the arthritic care in your experience, please.
Uh, but I would want you to clarify that question. Are you asking me about we working in the hospital between the different departments, or you're looking asking me about as a
So this will be a broader question, including you working in the hospital as a multidisciplinary approach, talking about how has the multi-departmental and the collaborative efforts between different departments proven to combat arthritic cases better is my precise question.
all right. So from okay, I'll answer that question. What has happened is with awareness coming through, our medical colleagues are picking up arthritis way better.
Mm-hmm.
There's an awareness going around. Our cardiologist colleagues are picking up. See, in the end, obesity has become a problem. So if they are losing mobility, it's been picked up to say kindly go and see the orthopedicians to see what they can do to help you. That is being actively done. So I can vouch for that, at least in our center, that we are looking at a person from that perspective, that where can we settle you down. All right. The second part of this question is from a surgical. I'm a surgeon, so coming from a surgical perspective, the type of surgical techniques we use, and in addition to the anesthesiologist, the type
Mm-hmm.
of anesthesia being given, the blocks being given, so the anesthesia has become much safer for these patients. Their intraoperative course is much more smoother. Post-operative pain management and complication rates have gone down drastically.
Mm-hmm.
At one time, not osteoarthritis, these other arthritis like psoriatic, rheumatoid would have a high rate of infection and other complication. Uh, I'm pleased to say that those rates have come down significantly. They're still high. I'm not saying they have become as low as, but like what has become to cataract, like cataract has become a routine surgery. I think
Right.
knee replacement is going down the same route.
Hmm.
Knee replacement is going down the same. I can vouch for that. Like I have patients walking into my OPD saying, "Oh, इनका ना knee needs a knee replacement.
Hmm.
So patient awareness, it's because see the outcomes are improving when we start giving out good results consistently. Different centers. My center is different to Dr. Jha's center. We are very near to each other, but two different hospitals. But when quality work is being done across centers, and I think a lot of us, again, I think our generation is slightly different. We are very supportive of each other. At least I always say to my patients, this is your treatment. You can go across the road to Fortis, you can go to Artemis, you can go to any place. Treatment yahi hai.
Right.
So what that does is, as you open up, they realize, and when they go and maybe meet Dr. Jha, he says the same thing. So
Then
what
they
that does is,
confide in the treatment modality. Right.
what it does is, it gives them confidence
Right.
that they are not being told something unique, or so
Mm-hmm.
that consistent message, when that goes, it goes longer.
Right.
The problem is when you give mixed signals.
Hmm.
I say something, the patient sees Dr. Jha and he says something totally different.
Right.
Fortunately, our generation, I think we are settling down. There was few issues initially. It was always a trend for doctors to rubbish the other doctor's prescription. I think that days are gone. We should respect each other's opinions, and most of all, we should try to make the patient understand that these things will have complications. Uh, every doctor is trying to do their best. We are not God.
Mm-hmm.
We will get good results, but there will be few complications. So saying that that complication happened there, so that was totally wrong. It's wrong. It's actually wrong practice.
Mm-hmm.
So when we all work together as a team, and it doesn't mean that working as a team is that you are working together in the same hospital. It's working as a team to give a like that security net.
Right, sir. Improve the
So at least
community outcome of that
the
particular
community
disease.
outcome, what it does is it helps everybody across the board,
Right. Yes, including the caregivers, including the physicians,
including the
and including the
caregivers.
patients.
See,
Right,
like
sir.
I said, it is we look at it as a medical problem. I look at it as a social problem.
Right.
Who talks about these caregivers? Tell me. If somebody
Not a
has
lot
got
of platforms.
arthritis who cannot get up and go to the loo, and somebody has to give them a hand to take them to the loo,
Right, sir.
I think they should be recognized.
Right, sir.
Somebody can't get
Very
up and have a cup of tea or coffee, and somebody gets them and makes a tea or
gets
coffee.
it for you.
We take it for granted in India. Trust me.
Yes, sir.
But you go abroad, you will see one over there a cup of coffee where the people live alone.
Right.
It's a sad state. In India, we are going down the same route. We are turning from
Mm.
a joint families to nuclear families, and from nuclear families, we are started living alone. So when
Right.
you lose mobility, your social interactions, we are social animals. So
Right,
the
sir.
moment you don't socialize, you start challenging the basic definition of being a human being.
Correct. And I think in the entire nutshell, it will spoil the quality of life for that
Absolutely. There are
particular
two
patient.
parameters which have to be addressed. One is quality of life. The second is activities of daily living.
Mm-hmm.
If we don't
Right.
address these two parameters, I think we are failing all treatments.
Right. Thank you, Dr. Jaggi, for that answer. Moving over, I would like to understand from both of you about any ongoing public health initiative which is focused on arthritic awareness, or maybe some governmental or non-governmental organization that is helping in raising awareness and providing support to arthritic care. So I'd like to understand both of your views on this and any organizations or programs that you're aware of. Dr. Jha, we'll start with you.
Okay, so there are two parts. One is about the say medical education part. Okay,
Mm-hmm.
so a lot of things is happening, like number of conferences, hands-on, cadaveric workshops, other thing, training of the young surgeons. These are going on, and there are
Mm-hmm.
many societies which are actively they are encouraging these things. In fact, if you see 10 years back, there were hardly one or two annual events, but nowadays monthly there are different events. there are different cadaveric labs in India which train the young doctors, like say Ramaiah Medical College in Bangalore or in Chennai also. So one thing is about the training the young surgeons to deal with these uh, arthritic problems. Second is about government level. So from
Mm-hmm.
government level, certainly they have very good intentions, like how they have started the Ayushman Bharat and other thing. So in some state government also they have given the insurances also uh, till some coverage actually.
Mm-hmm.
Third,
Mm-hmm.
they have kept some implants like knee replacement implants they have kept. So they are done under very like positive intentions,
Mm-hmm.
but it should be implemented very well. Like if say in district hospital, if they have started doing total knee replacement, it's a very good sign. It's a encouraging sign. But they should also look about their infrastructure because this kind of surgery is required a good setup. So
Correct.
setup is the first important rather than doing those surgeries. You are doing more harm than the good. I think Dr. Jaggi will agree. The number of complications we see from like those people coming from the remote is very very high. So if maybe it's their political like agenda to claim that this much surgery is being done at district level or small hospital or, but sorry to say, doing surgery is not important. Doing good surgery is important. So first
Right.
thing is developing the infrastructure is very very important. And
Mm-hmm.
certainly, maybe in coming years, if these are implemented well, honestly, so this capping, Ayushman Bharat, insurance, and other thing will help in long term. And in between, like training of paramedical staffs and other thing is also going very well actually. So physiotherapy, dietitians, psychological therapy, and other things. These are the different like ancillaries which are also working in that direction. So hopefully they should work well.
Thank you, Dr. Jha. Dr. Jaggi, anything you'd like to add on the public health initiative or the government, non-governmental organizations for arthritic awareness? Anything which you'd like to add to Dr. Jha's
See,
comment?
as far as arthritis awareness is there, there's nothing in India. It's a big zero. I can say that with I'm pretty confident.
Okay.
It's a big zero. There is, for cataract programs, there are programs for heart. So, these are politically driven programs. Iodine. So, they see which program with the least amount of money can go longer, which can give them more, you can call them brownie points.
Hmm.
Iodine dal diya, thyroid ko we fought against thyroid. So, there's hardly a cost. They have put it on the manufacturers to start adding this much iodine,
Hmm.
and they take all the credit for that iodine. So, unfortunately, India works on those politics. Arthritis is not a political, you might call it importance,
Hmm.
because the moment anybody gives any importance to this, Indian economy will go for a toss. It's nothing but wear and tear. So,
Right.
and public awareness uh, needs a very concerted effort. That information has to go in consistently. You can't have a one off big proclamation ki we'll do this, and suddenly
Hmm.
everybody goes home and then they clap, they go
No
home, take a
follow-ups.
and go to sleep,
Right.
and then after
Right.
5 years again we go and say okay, we'll do this.
Hmm.
So these are long term measures, and for long term measures you need to have quality people running it. Now where do
Correct.
you get quality people from? There's a cost involved.
Hmm.
Now who picks up this cost? So
The
there are
government.
too many question marks. So
Right. Right.
from a government point of view, nobody's doing anything. I think
Hmm.
people are small NGOs are doing specific work, and I know a couple of them, but those are very very specific and very personality driven. What happened is somebody was quite well off. their child had a problem or somebody had a problem, so they want to do something for a. But see, they can't like address it at a bigger picture.
Right.
So they are doing good work,
But at a small level and
but at a small level where they're
mind.
trying to do it for the local community.
Correct. Correct.
So we don't have a program, and unfortunately, we should have a program,
Mm-hmm.
but there is none that I know of, because I'm quite connected with public health as well.
Mm-hmm.
So, as far as arthritis is concerned, it is too low down on the priority list.
I see.
It
I
doesn't
see.
make headlines.
Hmm.
The problem with arthritis is nobody dies with arthritis. If tomorrow the prime minister dies with a heart attack, or somebody else important, chief justice, or somebody has a heart attack, or I'm saying it's a complication, but
Mm-hmm.
stroke ho gaya, it's suddenly, you know, the
Catches
moment it
all the
is not
eyeballs.
life threatening,
Huh.
the focus changes.
Right, sir. Right. Thank you, Dr. Jaggi, for this answer. Moving over to the last two parts of our conversation. One is going to be talking about technological solutions and innovations. So I'll start with Dr. Jha. Any recent technological advancements or digital tools that have helped you and you feel are having some proven beneficial addition to the management and treatment of arthritis, sir?
See, if you talk about the tools, so there are certain apps which are now they have started helping the patient about their records. First is record keeping. Second is coming to the cure. So, being a surgeon, we have access to this computer navigations, robotic. So these are the tools which are like say AI based. They helps in implantation of
Mm-hmm.
say for total knee replacement, implantation in accurate position. So this is one of marker actually, one of out say inputs actually.
Mm-hmm.
It's not the only thing. So total knee replacement, say for osteoarthritis knee, is the treatment. There are different ways to go there. So certainly technology helps in finding this solution, but it is not the only one. The traditional way of conventional TKR, the outcome is similar as compared to the robotic one,
Mm-hmm.
but certainly there are important technological improvements, computer-assisted surgeries, minimally invasive surgeries, advent of new implants, which has very long life actually, longevity of these implants, and robotic surgeries.
Thank you, Dr. Jha, for that answer there. Moving over, Dr. Jaggi, my next question will be for you. Please put some light on some preventive measures that individuals can take to reduce their risk of developing arthritis, if there are any. Please.
Uh, See, this question will be essentially for osteoarthritis, because other ones is their genetic. Like if you have rheumatoid
Hmm.
or these things, you can't really do anything to prevent it. It's an
Hmm.
autoimmune problem.
Right, sir.
Coming to osteoarthritis, the biggest thing is a lifestyle.
Hmm. So please
Weight
put some
is
light on
the
some measures and
yes,
some takeaways. Right.
yeah. So the biggest thing is weight management. So we have to break certain myths.
Hmm.
We are all living longer. The longer we live, we are using our joints that much longer.
Correct.
Think of it like a tire. You're keeping your car for a longer period of time. You want to make it last longer. What do? Make sure you don't put overweight on that vehicle, so that the maintain the pressure in the tires.
That's
Don't
right.
brake too hard. Don't accelerate too hard. So understanding your limitations. A lot of the times I see patients with joint problems are because they suddenly get up one day and say we have to go to the gym and run on the treadmill, or
Hmm.
I have to do something called as burpees and squats. So what I'm trying to say is, one, understand your body, try to maintain your weight in that healthy zone.
Hmm.
The, the lighter you are on your feet, the less chances of you developing any sort of injuries to your joints. When you, the second thing which is of extreme importance is, whenever you have an injury to your joint, please
Mhm.
address it at the right time,
Right.
because a lot of osteoarthritis we see now is some trauma to the joint which happened 15-20 years ago. Maybe a tear of the cushion or tear of the ligament, something had happened and nothing was done.
Hmm.
So if you have a tire which had a small puncture and you just keep running with it, it will deflate. You put more air on the, it just that thing, it will just break the. So what happens is, one, keep good care of yourself when you are in a younger age group. Maintain a healthy lifestyle, maintain a healthy weight, do exercises which, because if your muscles are strong, there is less weight or stress coming onto the joints.
Right.
So sedentary lifestyle is actually bad, and this misconception that we will use them less so they will last long is a total misconception.
Mm-hmm.
कम चलेंगे तो ज़्यादा it is wrong.
Right.
The more you use your joints, actually, the more supple they become, the longer they last you.
Right.
So, some information, but essentially looking after yourself and addressing issues at the right time. Whatever
Mm-hmm.
the treatment, a lot of people with knee problems, when they come, if it needs to be addressed, they will not address it, they will end up with a back problem. So, initially you start with a knee problem, but now you have a knee and a back problem.
Right.
So, it's
Yes. Yes,
essentially
Dr.
a
Jaggi.
healthy lifestyle, but
Mm-hmm.
also addressing issues appropriately when they arise.
Right. Focusing on early diagnosis and
Early
early
diagnosis
intervention.
and the appropriate treatment.
Right, right. Thank you, Dr. Jaggi. So with this, we are just towards the closing of this panel. So I would like to first of all thank Dr. Jaggi, thank Dr. Jha for spending your valuable time in helping us discuss about the different parameters that there are in arthritis to discuss of. Any my last question, last key takeaway that each one of you would like to give across to all our viewers on this arthritic awareness campaign. We'll start with Dr. Jha. Your key takeaway, your key message to anyone who is watching this video, any caregiver, a fellow doctor, or a patient, or just a general public. So your message towards them for arthritic awareness, please.
So, my take home message would be take care of your joints, they will take care of you. Maintain healthy weight, eat balanced diet, healthy diet, manage the micro trauma. If pain persistent more than 3 weeks for some reason, pain and swelling, consult doctor
Mm-hmm.
and try to take expert opinion, specialist opinion if pain and disability is there in your life because of this arthritis.
Thank you, Dr. Jha, for that insightful answer. Dr. Jaggi, your key take home message for all the viewers, please.
My take home is what I would totally agree 100% with what Dr. Jha said. I would just add a couple of lines to it is that, one, uh, don't be afraid. See, a lot of the time there is this, people are afraid of a treatment because they have some misconceptions. They don't
Mm-hmm.
want to talk to the right person. They just say, "Usne aisa kiya, usne I heard, I know some." There is these vague things. So this is a lot of misconceptions. What I'm saying is, any problem you have right now, medicine has advanced enough in almost all the fields that please go and see and talk to the relevant people and see what is there which can be offered. If you don't understand your reality, the problem is, if you are not very sure of the reality, or if you are not very ready with your reality, and you are in a different zone altogether, sometimes patients come to you and they're so afraid that something is good, and you tell them it's nothing. They're like, wow, we thought. So what is happening is, when you close yourself, there is that, I don't know why, but there is this fear. So instead of being fearful, start trusting. Instead of
Mm-hmm.
asking Google or chat GPT for a diagnosis, talk
Consult.
to a expert and take their opinion. See, in the end, what will Google or chat GPT tell you? Whatever you type in, it will give you back. That cannot take your clinical parameters into place. So that has to be understood. A lot of the patients would come and say, we were very afraid. I typed into Google and it said it could be this, this, and this. So they think of the rarest of rarest things, and common sense goes out of the picture.
Right. Right.
So awareness and that fear that something wrong, instead of being fearful, get up, look at your symptoms, be open, be open to that concept that yes, this is a problem, I may need some investigations, there might be a treatment. So what's wrong? If your car is not working, you take it to a workshop. What do you want? Your car to come back in a working condition.
Right. Very,
So,
very, very appropriately said, Dr. Jaggi.
so humans, we are so willing. It's actually sad that we are willing to give away this gift of mobility we have. See, trees are alive, they can't walk. Animals, they walk on 4 feet. We are walking on two. We are a blessed species. But we so easily give up on blessings.
Right, sir. Right. Thank you, Dr. Jaggi. Thank you, Dr. Jha, for having this elaborative discussion. With this, I'd like to bring this session to an end. I'd like to thank Pfizer. I'd like to thank all the viewers and my panelists, Dr. Jaggi, Dr. Jha, and Dr. Naval, who were a part of this conversation. And you stepped up and took a step along with Voice of Healthcare in the initiative for arthritic awareness. I thank you people for joining, and have a good day. Thank you.
All right. Thank you. God bless you. Take care.
Thank you, sir.